morning. I'm Michelle Levander, Director of the Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, which asks, can our healthcare system provide a good death? This webinar series is offered thanks to a generous grant from the National Institute of Healthcare Management Foundation. We'll take it for our point of departure on this conversation, the fundamental questions raised by the Institute of Medicine in its report on dying in America. Leonard Schaefer, one of our speakers today, served as a member of the committee of experts who wrote that report. It found that while it is possible to improve Americans' experience in their final years, a host of obstacles gets in the way, many of them built into our healthcare system and into our culture. Our healthcare system provides financial rewards for unnecessary interventions at the end of life that can turn death into a hospital spectacle, rob patients of their dignity, and lead to mounting healthcare costs, the IOM found. As America's population ages, these policy questions become more urgent every day. That's especially true for Ann Newman, our other speaker today. She started on a 9-year quest to explore dying in America after dealing with her father's devastating death in 2005. She has since spent days and years in hospitals and as a hospice volunteer, concluding in her critically acclaimed book that a good death isn't possible today in America. What had it all been for? The worry and pain and wasting away, the puke bucket and the sleeplessness, she wrote. Dad had not died the way he wanted. We're really honored to have these two expert speakers to help us explore this landscape. A bit more about their backgrounds. Leonard Schaefer, a professor at the University of Southern California, was the founding chairman and CEO of WellPoint, now known as Anthem, one of the nation's largest health insurance companies. In the federal government, Professor Schaefer served as administrator of the Healthcare Financing Administration, where he was responsible for the Medicare and Medicaid programs. In 2009, Professor Schaefer established the Schaefer Center for Health Policy and Economics at USC. Ann Newman is the author of the critically acclaimed book, The Good Death, An Exploration of Dying in America, and a visiting scholar at the Center for Religion and Media at New York University, where she writes the monthly column, The Patient Body, about the intersection of religion and medicine. Newman is a contributing editor at Guernica, a magazine of art and politics, and has taught journalism at Drew University and New York University. Her work has appeared at the Washington Post, the New York Times, the Guardian, New York Law Review, and elsewhere. Before we get going, I wanted to share a few housekeeping matters. First, we'll hear from our two panelists, and then we'll have about a half hour to take your questions. We have more than 250 people signed up for this webinar, so we'll ask you to raise a virtual hand on your webinar dashboard through the chat or question box. That's also the place to let us know if you have any technical difficulties. Should you want to tweet about this webinar, the hashtag is GoodDeath. We'll also be recording and archiving our conversation. So we're going to get started now. Professor Schaefer, help us understand these pressing issues.
Thank you, Michelle. Like most people, I'm interested in efforts to improve end-of-life care for both personal and professional reasons. In my remarks today, I'll review the recommendations of the National Academy of Medicine's report, Dying in America, which describes the difficult experiences that many people and their loved ones have had in their final days. Those descriptions resonated with me as my mother had some unnecessary and painful treatment experiences at the end of her life. From that experience, I came to believe that patients should not have to confront a healthcare system that doesn't allow them to influence decisions about how they maintain their quality of life and how they die. The Dying in America report begins with answering the questions, why improve end-of-life care? In the U.S., death has evolved into a medical event, but for many patients and their families, the most pressing needs are actually social, emotional, and spiritual. Over 10,000 baby boomers a day turn 65, but studies show that most of them, 80%, actually prefer to die at home, while only a third do, a third of Medicare beneficiaries. A fundamental problem with our healthcare system is that it does not deliver care that's consistent with patients' values and preferences for the quality of life they want at the end of their lives. The cultural diversity of our nation increases the needs for physicians to inquire about and to document patients' values and preferences. They can't make assumptions about how different people want to die. And delivering those services that people want near the end of their lives is made more difficult by our fee-for-service reimbursement system. Fee-for-service encourages intensive medical care at the end of life, However, research suggests that higher Medicare spending does not increase patient or family satisfaction. The Dying in America report recommended changes in 5 key areas to transform end-of-life care. The Consensus Committee identified these 5 areas where change is necessary in order to align clinical practice, public policy, and patients' personal preferences. Taken together, these 5 areas create a framework for improving the most important dimensions that impact end-of-life care. So let's take a brief look at each set of recommendations. The first recommendation is that a person-centered, family-oriented approach that promotes quality of life through the end of life should be a national priority. Unfortunately, people near the end of life often experience multiple transitions between sites and caregivers. Such a fragmented care is burdensome for families and inhibits patients from receiving palliative care. Pain-reducing palliative care increases quality of life. Research shows that patients receiving palliative care live longer than those who don't. The Dying in America report also recommends that government and private insurers cover what's called comprehensive care for people with advanced illness. Comprehensive care means consistently accessible care that's seamless over these transitions, that's integrated, and that includes supportive services that address the emotional, social, and spiritual needs of patients and their families. To ensure high-quality care near the end of life, payers should be held accountable by requiring them to report quality and cost metrics. The second set of recommendations, communication and advanced care planning, is essential to transforming the system. Good communication is at the core of delivering care throughout our healthcare system. But many people near the end of life are not physically or mentally capable of making decisions about their own care. Unfortunately, most will receive care from providers who don't even know them. So clinician-patient communication should occur on an ongoing basis well before end of life. And preferences should be elicited and stored electronically in electronic health records to ensure that patients get the care that reflects their personal values and that they have access to palliative care when they want it. Professional societies and other organizations should develop standards for communication and advanced care planning. Standards that are measurable and evidence-based are how we'll know if patients are receiving quality care. Finally, payers and healthcare delivery organizations should adopt these standards and tie performance to reimbursement. The third set of recommendations involves professional education concerning death, dying, and palliative care. The good news is that progress has been made in establishing hospice and palliative care medicine as specialty practices. But to date, the demand for expertise in hospice and palliative care far exceeds the available supply. According to the Dying in America report, a range of organizations, especially medical and nursing schools, must take actions that include training, certification, and licensure to increase the number of palliative care specialists and to expand the knowledge base for all clinicians to ensure that they know how to communicate well with patients near the end of life, regardless of their specialty. The Dying in America panel also wanted to tackle the issue of financial incentives that undermine efforts to align care with patients' values and goals. The panel focused on how current fee-for-service financial incentives encourage acute care that does not match the medical and social needs of patients and that is unnecessarily costly. The panel also recognized that palliative care services may lower costs by reducing emergency room visits and hospitalizations while improving quality of life. So the committee recommended a major redesign of payment systems away from traditional fee-for-service to encourage 3 important behaviors. First, integration of medical and social services to reduce the need for emergency room visits and acute care services. Second, coordination of care across all care settings, home, hospital, nursing home, etc. And finally, the use of advanced care planning and shared decision-making. That's making people aware of their options and involving both patients and and clinicians in making decisions about care. The panel recommended that providers should be paid to document and deliver this integrated care that patients want. It's very encouraging to note that after publication of the Dying in America report, CMS announced it will pay physicians for end-of-life counseling as often as necessary. It's very important that these discussions begin before becoming involved in serious or serious illness. CMS will also pay for nurse and social worker visits in the last week of life. The panel also explicitly called for legislative action to improve Medicare reimbursement should it become necessary. Finally, the report calls for federal programs to require public reporting on outcomes and costs to assure accountability to the public. The fifth area for recommendations centers on public education and engagement. And as I mentioned, most Americans lack knowledge about their end-of-life care choices or how to express those choices. So the Dying in America Committee identified a need for public education and engagement about end-of-life care planning at several different levels. First, the societal level, to build support for public and institutional policies that ensure high-quality care. Second, the community and family levels, to raise awareness about care options, the needs of caregivers, and we're talking here frequently about family caregivers, and it's very stressful, and the expectations for high-quality care. And finally, at the individual level, to facilitate advanced care planning and meaningful conversations with family members and caregivers well in advance of end of life. But obviously, healthcare organizations can't do this alone. They should be joined by civic leaders, faith-based organizations, consumer groups, employers, and the media, and others, each of us as individuals, to help inform the public. All of these efforts must disseminate accurate information so that individual care decisions and public dialogue are informed and based on evidence. So, if all the recommendations made in the Dying in America report were implemented, what would end-of-life care look like? The committee's vision for a better system of end-of-life care would mean three big changes. First, patients would be respected and family members would be supported because they would receive medical and social services that reflect their values and preferences based on needs that change over time. Second, patients would experience fewer medical crises because comprehensive care that includes social supports would help avoid the kinds of problems that lead to ER visits and hospitalizations. And finally, society would benefit because restructuring the healthcare system to better respond to the needs of patients and their families is likely to stabilize costs. So I understand there are journalists who have joined us for this webinar, and the opportunity for journalists to play a significant role in improving end-of-life care begins with the observation that everybody has a story. And because most Americans have a story, the public is way ahead of politicians, the healthcare system, and the media on issues surrounding death and dying. Most Americans are aware of a difficult experience in the final days of a loved one's life due between the care that patients and their families want and the care they get. But most people, when they think about it and when they're encouraged, do have preferences about how they live the end of their life and how they die. So the report makes recommendations for improving end-of-life care that are a roadmap we can follow to achieve meaningful change. Journalists who can educate the public about policy and personal options for a good death can accelerate the cultural and systemic changes that we need. There are many stories to tell and many resources available. Anne is going to tell us some of these stories. But I encourage journalists and others interested in these topics to review the Dying in America report and the resources listed on the Health Matters website. including going to the work of the Coalition to Transform Advanced Care, which just conducted a very well-attended conference on this topic in Washington, D.C. That concludes my description of a very complicated report.
Thank you so much, Professor Schaefer. And you have tackled this at a deeply personal level, and also really hearing the story all over the country as you spend time in hospice and hospitals. Tell us a little bit about your perspective on this topic.
Yeah, first of all, thanks so much, Michelle Levander and Center for Health Journalism for having me. Ryan White for dealing with the technology, and Professor Schaefer for giving us this overview of your fantastic Dying in America report. I want to start with your last slide, Professor Schaefer, kind of the opportunities for journalists, and use that as a jumping off point for discussing some of the opportunities that I have found and the ways in which my research has kind of outlaid this dying in America or end-of-life landscape that we face. As movements go, I think we all know that policy and perhaps law are the last to affect change. What can push those regimes to change is often social pressure. And as journalists, social pressure can come from making these facts and data as relevant as possible and as compelling and as possible, which often means getting close to the bodies that are affected by these issues and challenges. That is what I found myself doing, and I want to take you today through a number of those bodies or individuals that I met in the course of my research. Thank you for being here. I guess my first story is very much like that of Professor Schaefer's and many people who write about end-of-life care. In 2005, found myself at home, not a place that a 38-year-old expects themselves to be. My father was about 10 years into a prognosis with a non-Hodgkin lymphoma. And so I took a leave of absence, and we both had expectations for how he was going to die. We thought that, according to maybe movies or books, that we'd tuck him into bed and give him some soup, and he'd tell us he loved us, and then he would close his eyes, and that would be it. But I promise you that was not how it went down. And so I was very much broadsided by the experience. And I was angry at my dad for dying the way he did. I was angry at our society, the hospice nurses, my family, and culture at large for not better preparing me for the most common event in people's lives, the loss of loved ones. Even our own deaths, I realized that I was very unprepared. And so I shuffled around for a while, not knowing what to do with my grief. And then, like any good reporter, I put my journalist hat on and decided to figure out what was going on. So I became a hospice volunteer. I figured if I sidled up to death and got as close to it as possible, I would have a comparison. I would know better if my father's death was common. And as a hospice volunteer then, I was able to get a better grasp on the scope of the end-of-life landscape and the challenges that hospice patients were facing. I think Professor Schaefer laid out for us very much what's at stake in end-of-life care and why it's so important that we get it right. Millions of people die each year, which would be a natural process, except that we know from data that many are not dying the way they want to. And we have a whopping, giant elder population coming at us that we are very ill prepared for. So it's stories like that of my father and other individuals who are in the midst of their last weeks, months, and years that we can learn from, and then through their stories examine some of the larger ethical and social challenges that we face. One of those individuals that I met in the course of my research was Bill Coleman. I, like many other people, was watching the media sensation That was the Terri Schiavo case, a Florida court case that had gone on for years and kind of again erupted into our national consciousness about 6 months before my dad died. And I returned to it a number of years later because I wanted to better understand the complexities of that court case. It is jurisprudence for patient autonomy, for patients having the ability to say what kind of medical treatments they do and don't want. Schiavo was diagnosed as in a persistent vegetative state, and her husband wanted to remove a feeding tube, the only thing that was keeping her quote unquote alive. Her family did not want it removed, and that's the nature of the case that came about. Again, a national sensation. And as I sat looking at this from my own position, I asked myself, where else in the country can a person be fed against their will, which is kind of what the court decided when they ruled that the feeding tube could be removed. So up until about the 1970s, death meant the almost simultaneous end of heart rate, breathing, and brain function. And those functions were divorced with medical advancements like respirators and defibrillators, and we were left with the brain. And the brain is still very much a mystery to us. And so in the case of Terri Schiavo, no one really understood, and we still have questions of social beliefs about what amount of brain function is necessary. So I asked myself, can a person be fed against their will? And that question asked open-minded to a prisoner in Connecticut named Bill Coleman, who was on hunger strike because he contested his conviction and was being strapped down with court approval by the medical staff in the prison. And a rubber tube was periodically being shoved up his nose and down his throat and into his stomach and then filled with Ensure. So I initially corresponded with Bill, written letters, and I'll tell you, he's prolific. I have stacks of them here. And then I got onto a phone service, which is the only way that people can communicate with those in prison. It's pretty expensive if you want to talk about prison rights. But Bill and I spoke every Tuesday and Thursday for 15 minutes. It was recorded by the service, and I don't know, the prison staff probably could have listened to it. But I was regaled for those 15 minutes twice a week for a course of a year by Bill's state and throughout a lot of research. I learned a great amount about him. At first, it would seem a strange thing to compare, say, hospital use of feeding tubes for brain-dead patients or the use of feeding tubes in prisons for protesters or hunger strikers. But there's a lot to be learned about that comparison, about where patient autonomy matters to us and where it doesn't. I'm still friends with Bill, by the way. The good part of the story is that he's in the United Kingdom now. He was released from prison. He's from the UK. The bad news is that prisoners across the country are force-fed on a regular basis. And so my research revealed this to me in a pretty stunning way. Patient autonomy in prison is very much not patient autonomy elsewhere. This is Maria, and I have known Maria for about 6 years, maybe 5, going on 6. And I met her when I was assigned as a hospice volunteer to a very wealthy woman who lived on the Upper West Side of Manhattan. Her name was Eleanor. She was dying of lung cancer, and she was a doctor, so she kind of knew what was going on. But at the same time that she was in physical decline, her husband was also having health problems. So we asked around and got a recommendation for a home health aide, Maria. And I was there for the interview. We hired Maria on the spot because we were so desperate. And through my relationship with Maria, I learned an awful lot about the plight of home health aides. Maria, for instance, worked for $13 cash under the table. She had no sick leave. Her hours fluctuated based on the needs of the patients. She had no job stability or security. And often the individuals who do this kind of domestic work are women of color, sometimes undocumented, and so their positions are very tenuous. And yet, domestic AIDS or domestic labor is one of the largest growing job sectors in the country. As many people work to improve the job security and the job status of these individuals, the conversation tends to focus on the quality of their lives, doing some of the hardest, definitely literally the dirtiest work one can imagine. But an aspect of domestic care or home health aides that we need to also address is the great drain that it can be even on wealthy families. Even if you take this minimal, hard to live on amount of $13 an hour, multiply it by 6, 7, 8 hours a day, by months, by years, and you can see the amount of money that it adds up to. So not only did Maria teach me that we need to strengthen the quality and security of home health aides and their jobs, but we also have to address the resources that as a country we allocate to this kind of care. This is Bill Peace. I met Bill Peace, who's a paraplegic and an activist for disability rights, when he and I got into a furious fight online. This was a number of years ago, and it's a testament to Bill, probably not to me, that we're still good friends, basically because he took the time to school me. Not Dead Yet is the organization that Bill is a board member of, and yes, it is indeed named after the Monty Python skit. Not Dead Yet is comprised of disability rights activists who oppose aid in dying, the legalization of aid in dying. And as some of you may know, aid in dying is now legal in 5 states in the US. The most recent was California, which passed the bill. Governor Jerry Brown signed it into law in December. And people to those who live in states where aid in dying is legal. Not Dead Yet very much opposes this, and Bill taught me to be patient, to find the kernel of truth in his argument. 5 years after the passage of the Americans with Disabilities Act, the life for many disabled is one of challenge and compromise and hardship, finding solid work. Even, Bill told me a story one time about being invited to speak at a disability rights conference, getting there and not being able to get into the conference room because there was no ramp. So I've learned a lot from Bill over the years, but in my research I found that that the disabled are not necessarily at risk when aid in dying is legalized. So I think part of this conversation, part of understanding of Bill's position and of those who are proponents of legalization of aid in dying, is pulling apart the ethical challenges and looking at the statistics. I think Bill's emotional opposition is very much legitimate. He realizes that his community is marginalized and is not treated equally. But then there are those who want aid in dying legalized. And here's an aside, aid in dying looks like this. Individuals who have 6 months or less to live are able to receive a lethal medication from their doctor that they then must self-administer or not. It's up to them whether they choose it or not, but they have to take the medication themselves. So matching up Bill's position and activism to those who are pushing for the legalization of aid in dying was an incredible lesson, and I'm lucky that we're still tight. This is Monroe. So I told you about Eleanor, my wealthy patient on the Upper West Side who was dying of lung cancer. I met her and kind of fell in love with her, which is not hard to do when you're a hospice volunteer. And knowing her over the course of many years, because she was an uncommon patient. Hospice is typically 6 months, a 6-month window, and Eleanor was in hospice for over 5. She lived longer than we ever thought. But over the course of this time, I got to meet Monroe, and Monroe was her husband. He was there, as was Maria, as was I, when Eleanor died on December 2nd this past year. Strangely for me, a full circle December 2nd was the 10th anniversary of my father's death. But I also knew from my research when Eleanor died that immediately Monroe's mortality rate was 30% higher than any widow or a married man. And so I have stayed on with him, and I continue to visit him on Sundays, just as I did his wife. Some of the challenges to Monroe's health at the moment: he's 92, he's grief-stricken. He was with his wife for more than 50 years. His mobility is rapidly decreasing. He's got gout and all sorts of ailments that prevent him from feeling his feet well and being able to get around. His eyesight is going. And probably the greatest blow to his dignity is loss of continence. So he's no longer able to control his bowels or urinary tract. And so these are the challenges that Monroe faces. And I look at him on a regular basis and think, well, in how many years will this be me? Will I face these numbers of challenges as well? And I think that's one of the most important things about this kind of work, is not only the need to change policy on a broad scale, the need to make the public aware of what end of life looks like, but also to bring nuance and understanding to the lives of these individuals. What does that mean for a journalist as far as research and writing? It means asking as many questions as you can, being diligent in your research, conducting endless interviews, and making crazy piles of paper. As you can see here, this is what the book looked like at one point. The individuals that I met over the course of nearly a decade of research pointed me, or their stories pointed to larger issues in the end-of-life landscape. These are some of the most meaningful relationships in my life, and I would encourage you to consider the end-of-life care beat or elder care, because it's vast and very rich, and something that will in many ways touch your own life. Thank you so much for your time. My email address is there, and I hope that you'll send me questions if you've got them, and I look forward to our conversation now. Thank you.
Thank you so much, Professor Schaefer and Anne. This is really your chance in the audience to ask questions of our speakers, and you can go to the control panel and tap onto the question field and ask a question. In the meantime, while you send us a few queries, wanted to ask a question of both of our speakers. If you were going to pick one thing that would really make a difference in improving care and preventing some of the scenarios that have been outlined here so clearly, what would it be?
Well, the most immediate impact would be to change the way clinicians are trained and the behaviors that they go into in pursuit of their what they feel are their responsibilities to their patients, which frequently amounts to extending life, whatever the consequences are. And that is noble, but the question is that what the patient wants? And we need to have physicians and other clinicians trained to elicit the preferences of their patients, and then we need the system to provide what patients want in the way of their personal goals or personal preferences, and that's just not the way most professionals have been trained. So I would think training and behavior of clinicians is the most important thing to change.
Yeah, I'd have to agree at the moment with Professor Schaefer. And you know, as I've looked at the hospice terrain over the past few years, I think there's a quick fix or something like it that we could pursue. So perhaps the problem of doctors to be getting through medical school and even into their residency before seeing terminal patients could be, you know, we could do a quick fix by having them spend a semester as a hospice volunteer. That alone would meet two needs: the very dire shortage of hospice volunteers, but also the lack of exposure and experience of doctors in training. So maybe putting together two needs would be a great, efficient manner of addressing it.
Thank you. And another question, which is, have either of you come across in your research some real-world examples of healthcare organizations in the private sector that are avoiding this culture of overly intervening and maybe not respecting or listening to the family or patient's wishes as a way to improve end-of-life care?
I think there's really good news in that respect. I think we have to say, on the one hand, most Americans don't have access to programs that, quotes, do it right. But increasingly there are programs, and they are expanding. Cambia Health Solutions has what they call a personalized care support palliative care program. They have about 1.7 million people in that program. They're in the Northwest. They have reduced hospital admissions for people with serious illness by between 25 and 30%. Highmark is a blue insurance company in Pennsylvania, and they have something called Advanced Illness Services. And this program serves very ill Medicare Advantage beneficiaries who live at home and want palliative care. And the patients get visits in their home from palliative care professionals, but the palliative care is concurrent, simultaneous with the curative care. And there is in medicine a tension historically between the clinicians who do curative, we're trying to help you recover, and those who do palliative, which is we're trying to impact quality of life. And this program in Pennsylvania is pretty good. Aetna, who's a national insurer, has a program that's been around for almost 10 years, and it uses what they call a comprehensive case management approach. And nurse care managers who have special training in palliative care work with Aetna's Medicare Advantage members or covered individuals, and they provide integrated care. So, I would urge people who are thinking about their insurance coverage as they age to inquire about whether the insurance company has these kinds of integrated or comprehensive programs. There are many care deliverers who do this well, but since its care is across multiple locations, it turns out that insurers or large healthcare delivery systems are best at coordinating all the activities that need to be coordinated to provide a seamless program.
Yeah, and Aetna and these other programs that kind of set aside the non-curative demand that Medicare has had for so long on hospice care. These are fantastic programs. I'm going to come at it slightly askance. I think that the earlier we have patients talking about their medical choices and desires, the better. And I think simply just training doctors, again, one small intervention into the medical training process, training doctors how to discuss terminal diagnoses and to initiate these conversations would go a long way. The sooner that we can reach patients and have them talking frankly about what their desires are, the better.
Yeah, there's a technical point I should have mentioned that Anna's pointing out. These programs, to the extent they impact Medicare eligibles, it's Medicare Advantage that's being used, and that's a program in which the traditional rules associated with reimbursement and coverage decisions in Medicare are left up to the Medicare, are not enforced as rigorously as they are in traditional Medicare, and it gives both the clinicians and the funders much greater opportunity for creativity and for combining social, medical, and spiritual support. This is complicated stuff. One of the reasons it isn't done all that well is that it's hard to do, and you need a team, an integrated team that typically has physicians and nurses, but also needs social workers and home care aides, and as Ann was describing, hospice volunteers. You got to go out and help the folks wherever they may be.
Yeah, I think some of these programs are fantastic. One of the challenges is that in many cases they have to be patient initiated, and patients can be hesitant to start these conversations on their own. So overcoming that is, I think, one of the hurdles that we need to address.
Absolutely.
I have a question for Ann from Erica Hensley. She says, I'm a health journalist on the Senior Health Beat, and this is awesome. In your hospice experience, what kind of disparities did you notice with low-income patients, maybe without their own family caregiver, autonomy over their own end-of-life care? I guess, was there autonomy over their end-of-life care?
Yeah, it's hard to generalize in many ways. I think on the whole, the ethos that surrounds hospice is good and well-meaning and compassionate. I've had nothing but, for the most part, positive experiences. But hi, Erica, thanks for the question. I think just like any other national program, and I'll put that in air quotes because it's a loose term when you apply it to hospice, it's very much regional. So the ideas are shaped by the people on the ground in communities. And so you see a lot of variance about, say, the prevalence of religious language in certain places, or ideas about pain and who should have pain alleviated and when. And so this great variance makes it hard to generalize about the hospice experience. I do think, and in the book I am somewhat critical of hospice as, in many cases, ascribing one way of dying. You hold still in your own bed, and you have someone who comes and attends to you, and you kind of face your regrets and make your peace with family members, and then you're ready. And there's an infusion of kind of a pseudo-Eastern spirituality that has pervaded hospice practice in many cases, again, depending on region. And we just all know that everyone dies differently. So to ascribe one way of dying to any patient is a real challenge and not correct. But for the most part, I think hospice does an incredible job. The only thing that will make it stronger is increasing the resources that hospice can provide, the number of volunteers engaged with it, and greater awareness of it. When we see people who shy away from the word, for instance, the National Hospice and Palliative Care Organization thought about dropping hospice out of it. You'll see the conflation or restriction between the terms palliative and hospice. And while indeed they do different things, one is a kind of a regime of care, hospice, that's limited by government regulation, and the other is a medical specialty. But palliative care grew out of hospice, and so the relationship can't be fully severed. I just talked in circles around your question, but I hope that's helpful.
Thank you. We have a question for both of our speakers from Patty Moore, who asked if you could address the challenges for people with dementia, particularly Alzheimer's, who may live many years not being the human beings they want to be. Many want to end their lives. Where is this possible, and what has to change to make it possible more widely?
Well,
go ahead.
Please go ahead, Ann. Go ahead.
This is a really pressing conversation as we see the number of dementia patients or Alzheimer's patients rapidly increasing. And I know within proponents for aid in dying, for instance, there's been a large national conversation about how to best serve their needs. Because a patient must have their autonomy to make decisions, or to have stated that autonomy through medical proxies. Autonomy is a huge question. Like, is a medical proxy still valid if a patient can no longer affirm it? You know, patients' minds change all the time. So the challenges for dementia and Alzheimer's patients are great. There's a movement to increase awareness of voluntary stopping eating and drinking, which has the strange acronym of VSED. Of course, stopping eating and drinking is legal in all states, although there's still a lot of discrimination against it. There's a case of a couple, I believe, in New Mexico, the Rudolphs, who in their elder home decided to stop eating and drinking, and when the staff realized this, they reported them to the police, and the couple was evicted. So the challenges are great. How do we decide when patients are being told that their life is no longer worthwhile, and how do we decide when patients are still able to make their own decisions? We don't have clear answers. Probably comparing practice across the country and holding that next to individual cases is the best way we have so far.
Well, the issue of dementia at end of life raises all kinds of moral and ethical concerns, but it's going to end up, I think, in the courts, because there are just all kinds of legal issues. The thing that we all should do as individuals, though, is well before dementia, well before end of life, is to have conversations with loved ones about what your preferences are and what your hopes are about end of life, and then have a written advance directive, or sometimes called a living will, and identify a surrogate decision maker. So there is someone with whom you've had conversations, who knows you well, who can speak to what you want, not necessarily to what that person would like for you, but can speak to what you want, and then that person has the legal authority to make decisions. The question that emerges, and I think maybe the questioner is asking, is what happens if you're demented and perfectly healthy, and that period of dementia lasts for a long time before you become ill. If you then become ill and have what's called advanced illness near end of life, does your original medical proxy and does your original advanced directive still apply? That was the case for my mother. She had Alzheimer's. Then the average lifespan for a person with Alzheimer's from the diagnosis to death was about 8 years. Well, she lived another 10 years and had this problem that occurs. Alzheimer's first gets the cognitive activity in the brain, then the automatic functions. And so when she was drinking liquids, because she couldn't swallow very well anymore, the liquids went into her, that she got pneumonia. Now, 100 years ago, pneumonia was called the old man's friend. That's what most people died from. Well, today, nobody dies from pneumonia. They take you from wherever you are to the emergency room, shoot you up with these good drugs, and you go back home. That happened twice to my mother, and I called her physician, and I said, what's the prognosis? And he said, well, this will happen again and again, but don't worry, we'll keep her alive. And I said, well, I have her living will. I know what she wanted. This frightens her to death. She's panicked. She's sick. You know, this is not good for her. Don't you think hospice would be an opportunity? And I quote, he said, Mr. Schaefer, you don't want hospice. All they do is palliative care. 96-year-old woman, lost in time and space, frightened, sick, weak. Okay? Anyhow, she eventually got to hospice and had a peaceful and a good death. But the point is, if I hadn't had the conversation with my parents years and years before, if I wasn't absolutely convinced of what my mother would want and legally authorized to make that decision, she'd, well, I don't know what, but it wouldn't have been good.
It's a heartbreaking story, and the take your experience and multiply it by the number of patients across the country, and it's really sad. I'm glad you just gave us a full account.
Thank you,
Well,
Professor.
everybody has to
for sharing that. Go ahead. I didn't mean to interrupt you. Go ahead. So we have a question from Ron Hammerly. It's kind of about California's new end-of-life option, and he sees that it's exposing what he calls profound differences in how our healthcare system is responding to medical aid in dying once such aid is decriminalized. And he gives 3 examples. I was hoping you could comment on it. I'll try to sum them up quickly. He said the Western Regional Division of the Adventist Health System changed its longstanding policy and now says it's a matter to be decided between a patient and his or her physician, whereas Adventist Hospital Administration locally has said his hospital will not participate. And then the Huntington Hospital in Pasadena, meanwhile, is publicly announcing it would not participate and then changed its position and ran ads to say so. And Kaiser and UCLA have publicly stated they will honor their patients' choices. It seems like the way that we're talking about doctors grappling with this has also played out with individual hospitals and healthcare administrators. I would be very interested in both of your perspectives, and I know our audience would too.
Well, aid in dying is different than the end-of-life care issues that this National Academy of Medicine thing focused on. So there were no recommendations about aid in dying. The moral and ethical concerns that different people have around assisting a person to end their life makes this a much more fraught kind of discussion. However, when there is a law that authorizes it, it's clearly legal, and each of these institutions is trying to make known their policies about people who would like to take advantage of the law. But it's very different than the palliative and hospice care that we were talking about earlier.
And the distinction very much matters. Again, the definition of aid in dying as it's legal in Oregon, Washington, Vermont, and California, New Mexico, depending on who you talk to. The definition is a patient once or twice requesting a lethal medication, receiving it from their doctor, but having to pick it up themselves and having to self-administer it. That's very different from hospice. There's no relation whatsoever, although most of the patients who select aid in dying, who choose to use it, are hospice patients. The problem in many cases of full adoption, so now that we've got California has legalized these other 4 states, there are hospitals within those states that do not wish to comply. For instance, and I have a whole chapter about this in my book, Catholic health systems, for theological reasons, do not comply with aid in dying, and as we well know, a whole host of other services, particularly regarding reproductive justice or reproductive services. And because of the way that our religious exemptions work in the law, those hospitals can operate according to their own, they're called ethical and religious directives. They're written by the United States Conference of Catholic Bishops, they're approved by the Vatican, and they do indeed deviate from standard medical procedure because of theological opposition. And so the challenge will be for patients to push on these institutions when they are not able to access their rights, but also for these institutions to find a way to accommodate patients, mostly patients from a pluralistic society. You know, if you have an experience on the street in front of your home, you're going to be taken to the closest hospital by an ambulance. And if that happens to be a Catholic hospital, you better know what you need and how that hospital may or may not comply. This is a problem with women who have babies in Catholic hospitals and immediately want a tubal ligation. They have to go to another hospital at a later time for another invasive surgery, just as patients with removal of feeding tubes. After the Terri Schiavo case, which I mentioned in my presentation, the ethical and religious directives were changed to say that the removal of that feeding tube from a persistent vegetative state patient is up to the hospital administration and not the patient or their family. So these deviations make a huge difference. How California, how Catholic entities in any of these states are going to deal with aid in dying, legalization of aid in dying, is probably try to ignore it as long as they can and not comply.
So we have a question or a comment from John Radulovich, who says, we seem to be getting the message that it's impossible to get good end-of-life care in the U.S., yet 1.5 million people take advantage of hospice care every year.
Yeah, the problem with that is the deception of numbers. We all know that hospice is a 6-month program, but the mean stay, the last time I looked, was about 7 days. And that's a real challenge. So you find patients running through treatment after treatment that have proven to be non-curative, that have not helped them, and probably in many cases have made them even more uncomfortable or put them in more pain than before. And then finally, being told about the hospice option or making their way to a hospice program and really not having the time to take advantage of it. And so we're not doing a good enough job of getting those 1.5 million patients to hospice resources as soon as we could.
Also, I would say it's not impossible to get good or appropriate care at end of life. It's just that it's unlikely and it's difficult. And so the whole thrust of the recommendations from the National Academy's report was that we have to educate the public, we have to change the way clinicians are educated and how they practice, and we have to have conversations well before the incidence of actual death, so that people, loved ones, know what their loved ones would desire and have the legal right to see that happen. And then we have to train more palliative care physicians, and I think need more hospice. But things are getting better. They're just getting better slowly, and this is something we ought to do. We ought to focus on.
Yeah.
So we have a question from Marjorie Montemayor. Unfortunately, your second last name is cut off. It says, how can we pitch hospice end-of-life topics to media? One response I received from a reporter after a pitch was that dying and end-of-life are tough for mainstream publications. Any thoughts on how to make the topic more mainstream?
Well,
I think that used to be the case. And this Dying in America report, we started the consensus committee, I think, over 3 years ago. And one of the concerns was the political conversations around death panels, and how would this report be seen by the mainstream media? When we actually delivered the report, some 2.5 years later, we didn't get any of that blowback. We didn't get any of that kind of criticism. And the point I made earlier, there are over 10,000 people a day becoming eligible for Medicare. The population is shifting. People are beginning to think about this, and there is much more interest than I think either journalists or, frankly, clinicians are aware of, because this is something that every person is going to go through for himself and herself, and particularly older Americans have seen what happened to their parents or their uncles or some other family relation. So I think the populace is way ahead of the media and the clinical world. And so I think whatever mainstream media outlet thinks this isn't popular or interesting hasn't connected with where people are.
Hey, Marjorie, welcome to my world. I'm pitching stories about end-of-life care all the time, and what I've found is that the personal stories, being close to the bodies, like I was saying, is really important. Understanding and explaining the built-in drama of any life scenario, and I don't mean that salacious drama, but I mean the drama of life, and making that very clear in your pitch. This is a story that every one of us can relate to. And second, the thing that's been most helpful to me is finding editors that have a sympathy with the subject matter, either because they're going through it with their parents or a loved one. And they are out there, and they're not few in number. It's just really getting your pitch to the right ones, and that can make a huge difference for you. If I were you, I would focus on special issues. There are publications that are always approaching end of life or aging elder stuff. And there are columns, for instance. I wrote about Monroe and the plight of widowers for the New York Times Well blog. So there are editors that really do want these stories because they know how much it matters. And if you can find them, you'll be set.
We have a question from Gwendolyn Quintana, who says, in terms of evolving the healthcare system into a quality-based system rather than a fee-for-service system, what sorts of reporting measures might we expect to come out of palliative care in healthcare to increase patient-centered, quality-based healthcare?
Well, this is a real challenge, and there was a session at this CTAC event I mentioned earlier, focused on how to develop these measures. I don't know how often people in the audience go into hospitals, but I've been in a lot of them, given my background. And years ago, you had to complain in order to get any kind of pain medication. Now, if you're in a hospital, they will ask you, are you in pain? They will ask you to rate, on a scale of 1 to 10, how much pain, and they will provide medication in order to attempt to moderate that. And I'm not talking about end-of-life care. I'm just talking about anyone or almost anyone who's in a hospital. The issues surrounding end-of-life tend to be much more complex clinically, and I'm not a physician, so I have to be careful, because most of these folks have multiple chronic conditions. And so typically you're being treated for one or two other things in addition to the fragility of life. So one of the things that clinicians are working on, and what the Dying in America report recommended, is we have to develop measurements and methodologies to determine how people are feeling and how well the actions that are taken in end of life are ameliorating those problems. One last thing, just to make it even more complex, it turns out that end of life, on top of all of the clinical and medical issues, there is typically serious emotional problems that add to the intensity of discomfort, and in many cases there are spiritual issues, both solutions and anxieties that come up. So we have to develop a much more comprehensive way of assessing where people are as they come to end of life, and assessing the efficacy of the possible interventions that you can make. This is tough stuff, and as I said earlier, one of the reasons we don't do it all that well is it's very difficult to do, let alone measure.
Well, I think we've run out of time here. I want to thank everybody for this really vibrant discussion. I know we have a lot of other folks with questions, and I'm sorry we couldn't get to them all. I wanted you to know that we have resources at the bottom of the webinar page on centerforhealthjournalism.org that could help you with some further reading. We'll be archiving this webinar on our site. You can add to the Twitter conversation at the hashtag #GoodHealth. And I also want to alert you to the fact that we'll be sending everybody a very quick survey, and I want to urge you to take a moment to help us out and let us know what you liked about this webinar and what other topics would be of greatest interest. And I want to also thank our speakers for this tremendous mix of the personal and the policy. This was so compelling, and for our audience for asking such great questions. Thank you so much.
Thank you. Thank you.
Bye.